Mohit sir not yet joined.
मोहित सर अभी दिख नहीं रहे हैं। मोहित सर हैं? मोहित सर तो नहीं दिख रहे हैं।
He has joined. He has joined.
Yes.
हाँ, yes, join.
He has
Welcome,
joined.
sir. Mohit sir, welcome.
मोहित सर अनम्यूट कीजिए।
Mohit sir, unmute you.
Yes. Now if
Good evening to all of you, and first of all, congratulations to all of you for the landing of Chandrayaan-3, and this is the very good moment for us कि हम लोग अभी रिसर्सिटेशन का सीपीआर का हम लोग अभी सीएमई भी स्टार्ट करेंगे। उससे पहले हम लोग का चंद्रयान भी लैंड कर गया। तो very congratulations to all of you, and first of all I welcome our Chakra Rao sir, our chief guest. Thank you sir for coming here, sir. And now welcome to Dr. Mohit sir, our guest of honor.
Thank you so much
for this webinar, and also welcome our moderator Dr. Mukul Kapoor sir, Dr. Nishant sir, and welcome all our speaker, Dr. Abhishek, Dr. Joseph, and Dr. Silpi. Now we are start our regular CME for this month. Our topic is very important and very informative for all our PGs and everyone, also for the lay person. So it is very important topic. So first I want to Dr. Chakra Rao sir, please say a few words regarding CPR and all about our BJSA and our program, sir. Please, sir. Chakra Rao sir.
Thank you very much. Thank you very much for inviting me here as a chief guest. Actually, we are overwhelmed with joy today. Just about half an hour back, our lunar module has landed safely on the south pole of the moon, and it is a great success. Not only that, on June 1st of this year, we have achieved the membership in ILCAR. So all these days, we were thinking ILCAR, and we were also thinking of the resuscitation guidelines. And 2017, on the instinct of the Indian Society of Anesthesiologists, we have started to, and we have thought that we should have our own guidelines because of the conditions that are available in the Western world are absolutely different from India. We have not a complete wake-up of the emergency medical system. We have a lot of superstitions. We have a lot of myths and so many things. And sometimes even we are not able to afford actually the cost of the available trainings. So we could not train much of our paramedics, and actually we do not have an eye on that, and always the pre-hospital care is very much neglected, and most of the times the victim is brought to the hospital dead. So in these circumstances, we have evolved with some newer things which are suitable to India, which is actually realized now by the ILCAR. and they have started to set up the less resource countries guidelines also now. It has come into not existence, into light about 15 days ago. And this concept has came into openness when Rakesh and myself have visited South Africa. There the issue has come and it is coming. And now what we have to do is, even now I feel that the equipment that are needed to train the people, like the mannequins, are expensive in our way. And now there are one or two companies coming up with a low-cost mannequins at our request, and they are manufactured in India. Probably they will be good. I have not touched them. Actually, I have shown them. Of course, I have compressed in Mysore. And I request all of you to establish one comprehensive resuscitation training center in your institutions. This is most important because some of you, at least about 10 people, become the instructors. These 10 people on rotation, at least there should be 4 to 5 instructors in every teaching of about 30 to 35 members, and start training. So this will be helpful, and everybody should be trained, including the ambulance driver to the watchman or the chowkidar or the sentry fellow has to be trained, because we don't know where the cardiac arrest will come. Usually we always think of the emergency areas or the ICUs or high dependent areas, but we have to try. So we have to introduce the CPR training in schools. In schools, the school children will be at home, and about 80% of the cardiac arrests are occurring at home only. So like that, we have to improve ourselves. We have to train our family members. We have to train our neighbors. We have to train our relatives. We have to train the people whom we are meeting in the evenings in the club or the other areas. That's why. So our slogan is every citizen a lifesaver, and definitely the Indian Resuscitation Council is a combination of the pediatricians, the cardiologists, the IMA, actually the emergency medical physicians, the critical care people, and some of the obstetricians. So let us all work together to bring out a safe India. So your two hands, when you are outside the hospital, these two hands will save the life. So thank you very much. Please start the program.
Thank you, sir. Thank you. Now I request to Dr. Mohit sir. Mohit sir, please say a few words.
At the outset, let me congratulate the BJSA, Bihar and Jharkhand Society of Anesthesiologists for organizing such an event. As we all know, that CPR has become the buzzword in today's time, though it was, but recently it has picked up because of the landmark achievement of IRCF, especially in India, I would say, because since 2017, when IRCF was launched, naturally, a lot of awareness has been seen amongst the not only the professionals, but also the paramedics, the lay people as well. And if you see the statistics, only 2% are aware of CPR, but naturally, I think it is going to pick up, and because of the made easy guidelines, probably it is going to be much more easier for people to learn and much more penetrable to the general people as well. You must be all aware that 2020 has shown us and made us given us a very alarming picture as far as CPR is concerned. Whatever was achieved by the international guidelines they could only achieve that 40% of the people could be resuscitated by the lay people, though they are working for this for the last 60, 70 years. And if you see the research product, out of 491 recommendations, only 6 recommendations are evidence-based. So naturally, where are we as of now? Research is still there. We need to do a lot of work as far as CPR is concerned. So only 1.2% of the recent guidelines were research-based and evidence-based, I mean to say. And overall, if you see the CPR guidelines, most of them are opinion-based. Hardly there are any randomized control trial which has been there to, whatever we are doing is based on that. So we have miles to go, but yes, we are happy. We are really proud that seeing our credibility, the ELCOR has accepted us to be one of their members. And that's again a landmark achievement of the Indian Resuscitation Council Federation. And we are really happy that we are making people aware, the society aware, by conducting these type of workshops and these type of meetings, CMEs, which was not that much prevalent in the previous for the last so many years. Thank you to the society against the Bihar and Jharkhand Society of Anesthesiology for taking up this initiativeness for conducting CME on a regular basis, on monthly basis, and taking this topic as one of the major topics. Thank you so much once again. Over to you.
Thank you, sir. Syed Mohit, sir. Now start our semi. Dr. Jayaprakash, please introduce our moderator and start our semi. Unmute, JP.
Yeah. Now I would like to say that Dr. Nishant Kumar sir and Dr. Mukul Kumar sir is very senior and renowned figure in the field of anesthesiology and particularly this topic. So I would like to request to Mohit Ahmed sir. So please introduce our speaker because I feel that you are the best person to introduce.
Okay, thank you once again for giving me this honor. We have Dr. Nishant Kumar, who is also a well-known figure, in the capital city of India. He is a professor in the Department of Anesthesiology and Critical Care, Lady Hardinge Medical College and Associated Hospitals. He has been, and he is also an IIJ, editor of IIJ Airway Pain Management Therapeutics. He's a peer reviewer of national and international journals, publications of international, and there have been he has done a lot of national and national journals. And he had been also the part of consciousness team for sustainability in anesthesiology. His area of interest is, of course, critical care, TIVA, TCI, research methodology, and focus. Over to you, Dr. Nishant. We have another speaker. Of course, he does not need to have any introduction. Is one of the renowned personality who is keep making dent in every aspect wherever you just say. He is Professor Mukul Chandra Kapoor. He is the chief consultant and head anesthesiology and critical care, Amrita Institute of Medical Sciences and Amrita School of Medicine and Faridabad. He is also one of the scientific director of IRCF. He is also an associate member of the IGA of the American Heart Association. He has a lot of publications, a lot of achievement. You can speak volumes about him. Over to you, to all both the speakers. Thank you so much.
Thank you, Dr. Mohit. And thank you, Indian Society of Bihar and Jharkhand, for giving us an opportunity to moderate this very important session. I won't talk much on the need and the awareness that needs to be spread about CPR. Dr. Chakrao sir, Dr. Mohit have already spoken about it. I'm exalted. I'm really honored to have the pioneers of CPR in India, Dr. Chakrao sir, Dr. Mohit, Dr. Mukul Kapoor sir, and Dr. Rakesh sir, who have brought out the Indian guidelines, who are the part of the team who has brought out the Indian guidelines. Now, CPR is an important topic. And as sir said, that it depends on the evidence and the perception and the availability of resources. CPR is a constantly evolving branch. Now, I remember when I was a PG, we started with 363 shocks, then it turned to one shock only, then the energy changed, then from ABC it turned to CAB. So it has been an ever changing branch. So our first speaker, Dr. Abhishek Chatterjee, will be speaking on the clinical updates and perspectives, which is very important. And to introduce Dr. Chatterjee, he is a consultant and assistant professor at Manipal Tata Medical College, Jamshedpur, and he has been the ex-secretary of Jamshedpur City Branch, as well as he has been the joint organizer secretary for ISACON Bihar. And now he has had many publications and has been an eminent speaker at national and state conferences, and his areas of interest are, apart from CPR obviously, are obstetric anesthesia and ALD. So to present the first talk today, Dr. Abhishek Chatterjee. I welcome you. Thank you.
Thank you, Dr. Nishant. I hope my screen is visible.
Yes.
Yes.
Good evening, respected chief guest of honor, moderators, seniors, and my dear friends. At the outset, I express my sincere thanks to Bihar and Jharkhand Society of Anesthesiologists for giving me an opportunity to speak on such a lovely topic. Today, I'll be dealing with the clinical updates as per AHA 2020 guidelines, and I will also try and look at this from the perspective of International Liaison Committee on Resuscitation 2022. The main focus in adult cardiac arrest events include rapid recognition, prompt provision of CPR, defibrillation of malignant shockable rhythms, and post-ROSC supportive care and treatment of underlying causes. The recovery link highlights the enormous recovery and survivorship journey. Lots of emphasis have been given on post-cardiac arrest care and recovery in 2020 guideline as well as 2022 IL Core summary statement. If a victim is unresponsive with absent or abnormal breathing, the rescuer should assume that victim is in cardiac arrest. Abnormal breathing is characterized by slow, irregular gasping respirations that are ineffective for ventilation. We should not waste more than 10 seconds for checking a pulse. The two criteria, that is patient responsiveness and assessment of breathing, have been shown to rapidly identify a significant proportion of patients who are in cardiac arrest, allowing for immediate initiation of lay rescuer CPR. It is a class 1 recommendation that if the rescuer assumes that the victim is in cardiac arrest, then he should immediately start chest compression, because several studies have shown that the risk of harm to the patient is low if the patient is not in cardiac arrest. This is the adult cardiac arrest circular algorithm. And the emphasis is given primarily on chest compression rather than on ventilation. Now, coming to recommendations for opening the airway. A healthcare provider should use head tilt chin lift maneuver to open the airway. However, if a spinal injury is suspected or cannot be ruled out, providers should open the airway by using a jaw thrust instead of head tilt chin lift. Oropharyngeal and nasopharyngeal airways can be used to maintain a patent airway and facilitate appropriate ventilation. In the presence of a known or suspected basilar skull fracture or severe coagulopathy, an oral airway is preferred over the nasal airway because of the risk of trauma with nasopharyngeal airway. There is no evidence that required pressure facilitates ventilation or reduces the risk of aspiration in cardiac arrest patients. Required pressure may also impede ventilation and the placement of a supraglottic airway or intubation, and it also increases the risk of airway trauma during intubation. Now, coming to the further recommendation, the class 1 recommendation is that we should provide chest compression on the lower half of the sternum, because radiographic studies show the left ventricle is typically located inferior to the internipple line, which corresponds with the lower half of the sternum. And therefore, the middle lower half of the sternum has been selected for the site for chest compression. CPR should be performed on a firm surface and the victim should be in supine position. Several studies found better outcomes, including survival to hospital discharge and defibrillation success, when chest compression depth was at least 5 centimeters. Not allowing complete chest wall recoil has been associated with increased intrathoracic pressure and decreased coronary perfusion. Chest compression should be given at a rate of 100 to 120 per minute, and the chest compressor should avoid leaning on the chest between compressions so as to allow complete chest wall recoil for adults in cardiac arrest. Recommendations for ventilation during cardiac arrest. Studies have reported that enough tidal volume to cause visible chest rise, or approximately 500 to 600 ml of volume, will be sufficient. Excessive ventilation can also be harmful by increasing intrathoracic pressure, decreasing venous return to the heart, and diminishing cardiac output with poor survival. We must provide one breath over 1 second, and it is reasonable for a rescuer to use mouth-to-nose ventilation when mouth-to-mouth ventilation is not possible. And for a victim with tracheal stoma, we must provide mouth-to-stoma or face mask to stoma ventilation. Regarding the compression ventilation ratio, it should be provided in a ratio of 30:2. We must provide 10 breaths per minute, that is 1 breath every 10 seconds. Biphasic waveform defibrillators, which deliver pulses of opposite polarity, expose patients to a much lower peak electric current with equivalent or greater efficacy for terminating atrial as well as ventricular tachyarrhythmias, as compared to monophasic single polarity defibrillators, and therefore the biphasic waveforms are preferred. The pads or paddles can be placed in anterolateral, anteroposterior, or antero-infrascapular regions. The pads should be of at least 8 centimeters in diameter, and when VF or VT is refractory to first shock, and equivalent or higher energy shock may be considered. When VF or VT has been present for more than a few minutes, myocardial reserves of oxygen and other energy substrates are rapidly depleted. If chest compression is preceded before shock, then the success of defibrillation improves significantly, and therefore it is always advised to provide chest compression prior to defibrillation. Electric pacing is not recommended for routine use in established cardiac arrest. Coming to the vascular access, establishing a peripheral IV remains a reasonable initial approach, but intraosseous access may be considered when an intravenous is not successful or feasible. Central venous access is associated with higher morbidity, it takes time to perform, and it may also require interruption of CPR. Endotracheal drug administration is regarded as the least preferred route of drug administration because it is associated with unpredictable efficacy. Coming to vasopressor medications during cardiac arrest, epinephrine has been hypothesized to have beneficial effects during cardiac arrest, primarily because of its alpha agonistic effects, which leads to increased coronary and cerebral perfusion during CPR. The existing trials have used a protocol of 1 milligram of epinephrine every 3 to 5 minutes. Vasopressin offers no added advantage as a substitute for epinephrine. Amiodarone and lignocaine may be used if VF or VT is unresponsive to defibrillation. Beryllium and procainamide have uncertain efficacy, and sotalol requires slow infusion rate, and therefore it is impractical to use sotalol in a cardiac arrest scenario. Calcium, magnesium, and sodium carbonate, all these three agents should not be used routinely. Now coming to termination of resuscitation, the BLS termination of resuscitation rule recommends termination of resuscitation when the following criteria are fulfilled. Arrest was not witnessed by EMS providers or first responder, when no ROSC is obtained and no shocks were delivered. ACLS termination of resuscitation rule also recommends fulfillment of these criteria. Application of universal termination of resuscitation at 20 minutes of resuscitation was able to predict futility. Now coming to the newer developments in chest compression, nowadays ACD CPR plus ITD, that is active compression decompression CPR, along with impedance threshold devices, are considered to be an alternate to standard CPR. Active compression decompression device is a handheld device with a suction cup applied to mid-sternum, which actively lifts up the chest during decompression and thereby enhancing the negative intrathoracic pressure generated by chest recoil. The impedance threshold device is a pressure-sensitive valve attached to an advanced airway or face mask, which limits air entry into lungs during decompression phase of CPR. And in this way, it also increases the venous return and cardiac output. The extracorporeal CPR refers to the initiation of cardiopulmonary bypass during resuscitation of a patient in cardiac arrest. This involves the cannulation of a large vein and artery and initiation of veno-arterial extracorporeal circulation and membrane oxygenation. Now coming to specific arrhythmia management, the first one is wide complex tachycardia, which is defined as a condition in which there is rapid rhythm with a ventricular rate of more than 150 beats per minute, along with QRS duration of 0.12 seconds or more. If patient is hemodynamically unstable, it requires immediate electric cardioversion. And in cases of hemodynamically stable patients, rhythm diagnosis should be attempted by obtaining a 12-lead ECG. Adenosine is an ultra-short-acting drug that is effective in terminating regular tachycardia when it is caused by AV re-entry. Adenosine will not typically terminate atrial arrhythmias such as atrial flutter or atrial tachycardia. Amiodarone, procainamide, and sotalol are considered as broader spectrum antiarrhythmics and can treat both supraventricular as well as ventricular tachycardia, but they can cause hypotension. And any of these broader spectrum antiarrhythmics can also worsen wide complex tachycardia by converting them into a more malignant arrhythmia. And therefore, availability of a defibrillator is encouraged when these drugs are administered. Adenosine should not be administered for hemodynamically unstable or irregular rhythm or polymorphic wide complex tachycardia. Immediate defibrillation is recommended for sustained hemodynamically unstable polymorphic VT. Torsades de pointes is a form of polymorphic VT which is associated with a prolonged heart rate corrected QT interval. IV magnesium has been effective in suppressing and preventing recurrences of torsades. In the absence of long QT interval, magnesium has not been shown to be effective in the treatment of polymorphic VT or to afford benefit in the acute management of other ventricular tachyarrhythmias. Regarding the narrow complex tachycardia, synchronized cardioversion is recommended for acute treatment of regular narrow complex tachycardia in both unstable patients as well as in stable patients with failed pharmacological therapy. Vagal maneuvers and adenosine both have class 1 recommendation for SVT with regular rates. In hemodynamically unstable atrial fibrillation or atrial flutter, urgent direct cardioversion has class 1 recommendation. In management of bradycardia, class 1 recommendation is to try to find out the reversible causes and manage it. IV atropine has always been recommended as an initial agent, and if bradycardia is unresponsive to atropine, then IV epinephrine can be considered. In patients with persistent hemodynamically unstable bradycardia refractory to medical therapy, temporary transvenous pacing is reasonable. This is the adult post-cardiac arrest algorithm, which shows that after achieving ROSC, if a victim is still comatose and is not following commands, then we must go for targeted temperature management. The class 1 recommendation is to maintain a temperature of 32 to 36 degrees Celsius and at least 24 hours targeted temperature management should be continued. If cardiac arrest occurs because of ST segment elevation, then urgent coronary angiography should be performed. And during the adult post-cardiac arrest phase, we must try to achieve a systolic blood pressure of more than 90 with a mean arterial pressure of more than 65. SpO2 of 92 to 98% with a PSO2 of 35 to 45 is acceptable. Blood glucose should be maintained around 150 to 180 milligram per deciliter. And if the victim is having seizure, it should be promptly treated either with valproate or levetiracetam. Fosphenytoin is nowadays not recommended for its hypotension effect. This figure shows the recommended approach to multimodal neuroprognostication, which incorporates multiple diagnostic tests at least 72 hours after return to normothermia. Accurate neurological prognostication is important to avoid inappropriate withdrawal of life-sustaining treatment in patients who may otherwise achieve meaningful neurological recovery. There are certain clinical examinations which are done during neuroprognostication, like absent pupillary light reflex. If it is not, if it is present, that is, if the pupillary light reflex is absent up to 7 days after arrest, it is usually associated with poor neurological outcome. Quantitative pupillometry is the automated assessment of pupillary reactivity, which is measured by the % reduction in pupillary size. Bilateral absence of corneal reflexes and the presence of status myoclonus within 72 hours of arrest predicts poor neurological outcome. Certain proteins are released during neuronal injury, and one of them is neuron-specific enolase. A high serum values of neuron-specific enolase within 72 hours after cardiac arrest supports poor neurological outcome. And CT as well as MRI at 2 to 7 days are regularly used for neuroimaging during neuroprognostication. Regarding the recovery, the class 1 recommendation is that we must follow a structured assessment for anxiety, depression, post-traumatic stress, and fatigue for cardiac arrest survivors as well as their caregivers. Now, coming to special circumstances, the first one is anaphylaxis. Although anaphylaxis is a multi-system disease, life-threatening manifestations most often involve the respiratory as well as circulatory system. Intramuscular epinephrine is the preferred initial route of administration because of ease of administration, effectiveness, and safety. And IM epinephrine, the preferred site is lateral aspect of the thigh because it produces rapid peak plasma epinephrine concentration. If IV line is in place, then IV epinephrine can be an alternate to IM epinephrine. And when anaphylaxis produces obstructive airway edema, rapid advanced airway management is very critical. In drowning, class 1 recommendation is that rescuer should provide CPR as soon as the victim comes out of the water, and decompensation after drowning can occur in the first 4 to 6 hours. And therefore, all victims should be transported to a medical facility for monitoring for at least 4 to 6 hours. Cardiac arrest in pregnancy, the common causes are hemorrhage, amniotic and venous thromboembolism, sepsis, aspiration pneumonitis, etc. High quality CPR and relief of aortocaval compression through left lateral uterine displacement, prompt airway management, avoidance of fetal monitoring during resuscitation, targeted temperature management, and continuous monitoring for fetal bradycardia during targeted temperature monitoring all have class 1 recommendation. As soon as a mother goes into cardiac arrest, we must plan for evacuation of the uterus if the gestation period is more than 20 weeks. And to accomplish delivery easily, ideally within 5 minutes after the time of arrest, it is reasonable to immediately prepare for perimortem cesarean delivery. On the left-hand side is the algorithm for maternal cardiac arrest, and on the right-hand side are the two techniques, the two-handed technique and the one-handed technique for providing lateral displacement to take care of the aortocaval compression. If no ROAC occurs in 5 minutes, we must consider immediate perimortem cesarean delivery with availability of neonatal team to receive the neonate. Regarding cardiac arrest secondary to local anesthetic toxicity, the recommendation is to use IV lipid emulsion at a concentration of 20%, 1.5 ml per kg or 100 ml over few minutes, followed by 0.25 to 0.5 ml per kg per minute IV infusion. The successful outcome of cardiac arrest by following each of these components of care will definitely have a positive impact not only on patients, but also on families, healthcare providers, and the community. Thank you.
Thank you, Dr. Abhishek, for an interesting update and revision of the AHA guidelines. There are a few queries in the chat box. I'll read them out one by one. So the first query is that if hypoxia is the root cause of cardiac arrest, till what point is it recommended to continue CPR? So if we know the cause that it is hypoxia, so till what time should we continue CPR?
Well, if the primary cause of cardiac arrest is hypoxia, nowadays EtCO2 is gaining popularity. After securing the airway, if EtCO2 remains less than 10, even after 20 minutes of resuscitation, then it is considered to be futile. We can stop resuscitation at 20 minutes if EtCO2 remains less than 10. And if EtCO2 is more than 20, then we can continue with resuscitation measures.
So basically what you want to say is that the root cause of hypoxia, that means that an advanced airway or oxygenation has been ascertained, that there is an adequate chest rise, you are able to ventilate, oxygen is being provided. The root cause, which is hypoxia. Now hypoxia can take, we all know, we read in physiology, there are various forms of hypoxia, but at least you are providing oxygen to the lungs and it is being delivered to the tissues. That is what is there. And if you don't have ROSC within the next 20 minutes, that is, if the EtCO2 continues to remain less than 10, then you can probably cease your efforts. That means that you have done enough so that you're providing the oxygen to the lungs, but maybe it is not reaching the tissues because of so many factors which might be there.
Exactly.
So, right. Dr. Mukul Kapoor, you'd like to elaborate on this answer, sir?
Yeah, no, nothing more than that, but I would like to say that there are few changes as far as we are concerned in Resuscitation Council, I mean IRCF. The changes are basically related to things like we are recommending a rate of 120 compressions a minute, and secondly we
Sir,
also
we'll be discussing the IRCH guidelines next.
Yeah, so that was so I was saying, and then just pointing out that second thing is about the shock and the stacking of shocks, and which is a little different. Of course, I appreciate what AHA has written. It is not that, but I just wanted to point out that these are the differences which are majorly there. And I think there are two more questions which are, I think, at least about peri-mortem cesarean section that has been covered in this talk. This question was put before actually he talked about it. So that has been covered. And another question was atropine or adrenaline as the first line of treatment. I think he has very clearly mentioned that, Dr. Abhishek has clearly mentioned that, and that has been very well covered. I think we should, in interest of time, we should stop the discussion at this and rather go to the next speaker.
Okay, so today being an auspicious day when Chandrayaan has landed on the moon, and much like to give the same analogy, IRCH has done what ISRO has done. We had the AHA, they had their resources, it was an expensive thing, they have been doing it for 70 years. What NASA had been trying to do for the last 70, 80 years, now what India has achieved in much lesser cost, that is what IRCH has done, and it has got a far wider outreach than what AHA was able to achieve. As Dr. Mohit pointed out, that our outreach has been much better than what the AHA has been. Nothing to discredit AHA with, but yes, kudos to the ISS team. As again to say that Dr. Chakra Rao launched us into the orbit. The team IRCH, Dr. Mukul Kapoor, Dr. Mohit, Dr. Rakesh, and all other members have put us in orbit. Now it is on to us to soft land on the moon, that is to make it available to all the responders, be it healthcare, be it the layman. So the next speaker is Dr. Shilpa, a very young budding anesthesiologist, and she'll be taking us through the ICH guidelines. She is a first year junior resident at BNH Hospital, and she has worked as a MO in Bengaluru and with the Bihar Medical Services. So over to Dr. Shika, please, for her talk on ISH guidelines. She's there.
Regarding that, once
Dr.
this
Shilpi,
topic will
got your name.
this topic will over, I have many questions to Rakesh Garg boss and Mohit sir.
Yes, sir.
And we are there, but are you trying to give an alarm or make us scared?
No, because few questions I get from them, my audience.
Yes, sir. We are always there to, to fill up your,
Yes.
enthusiasm. Right, there's no issues. So many frequently asked questions are there.
Yes, you start now.
Dr. Shilpi, can we have your presentation, please?
Is my screen visible to everyone?
Yes, you can continue. Can you make it full screen, please? Please go ahead, Dr. Shilpi. It's again gone down. Yeah, please go ahead.
Good evening, everyone. As my respected previous speaker have already given an excellent insight, so I would like to talk in detail about the Indian Resuscitation Council's Cardiopulmonary Resuscitation Guidelines. The Indian Resuscitation Council is an initiative by Indian Society of Anesthesiologists to promote accurate and scientific resuscitation guidelines for training. It has been developed to recommend practical, uniform, and acceptable resuscitation algorithm across India. The guideline has been developed considering infrastructural limitations in most areas. So coming on to the major criteria or categories of the Indian Resuscitation Council CPR guidelines, the first being compression-only life support, which is also abbreviated as CALS, basic cardiopulmonary life support, and comprehensive cardiopulmonary life support. So before getting ahead, we must know what are the core links of survival. The optimal outcome of CPR would depend on focused links that need to be followed during the resuscitation. It is a metaphorical depiction of a series of critical events and actions required for management of cardiac arrest victims. Knowing, understanding, and appropriate execution of these interdependent key links improves the chances of survival. So getting ahead with the first guideline, that is compression-only life support, it's a yellow-coded algorithm. So the key highlight of this algorithm is that it is provided outside the hospital by an untrained layperson. So the three essential core links in compression-only life support would be the early recognition and activation, followed by early chest compression, and the early transfer of the patient to the nearest medical facility. So the first and foremost thing to be ensured is the place is safe, both for the victim as well as for the rescuer. So the places like of RTA, road traffic accident, fire hazard, or the area of electrocution or drowning, the patient or the victim must be moved away from such areas. The next would be to check for the response of the victim by tapping on the shoulders from the front and asking it loud, "Are you all right?" The language preferred must be a local language or the language that is understood by the patient. And while doing so, one must not make very big movements at the shoulder, because there might be an underlying cervical injury. So after checking for the response, there can be two conditions: that whether the patient is responsive. If the patient is responsive, he or she must be observed, put in a recovery position, and then shifted to the nearest medical facility. And if non-responsive, then the rescuer must shout for help, call 108, which is the national emergency number, and also can call a local emergency number. So what is to be said during the emergency call? The first most important thing is to identify yourself and the location, briefing about the number of victims present and the rescuers available, then asking for a defibrillator or automated external defibrillator or any emergency equipments. Do not disconnect the call in hurry, furnish all the information that is needed, and also wait for the person on the other side to confirm all the details that's heard by him. So this is the method of interlocking the fingers for giving chest compression, where heel of one hand is kept 2 fingers above the xiphoid process and the other hand is kept over it and the fingers are interlocked, while making sure that the fingers of the first hand does not touch the surface of the patient. And this is the correct posture to deliver the compression, where the rescuer's elbow needs to be straight, the shoulder should be above the chest of the victim, and the fingers being interlocked. The surface, the level of the knee of the rescuer should be at the level of the patient. So after checking for the response, if the patient is unresponsive, the chest compressions are started, which are delivered at a set of 5, that is, and each set comprising of 30 chest compressions. And then after delivering these compressions, one must check for the response if the victim is moving, coughing, or vocalizing. If the patient is responsive, then he or she must be shifted to the recovery position, reassessed every 2 minutes, and then shifted to the nearest medical facility. If still unresponsive, then the cycle of compression should be continued further. So this is the entire algorithm seen in one slide, from which ensures from the safety of the till going for the compressions and then looking for the response of the patient. So we must know what is the recovery position. In cases of spontaneous return of circulation and the normal breathing, the victim should be positioned in a recovery position till the medical help arrives and reassessed every 2 minutes. How long should the compressions be continued? It should be continued till the arrival of a trained personnel or a medical team, till when the victim is revived, that is the return of the spontaneous circulation. If the rescuer is exhausted and is unable to further deliver the CPR, or if the place or vicinity becomes unsafe. When not to start with the compressions or when not to give the compressions is when the scene is unsafe, or the patient is responsive, or the patient's body is stiff, like in the rigor mortis. Getting ahead with the second guideline, that is the basic cardiopulmonary life support. It's a green coded algorithm, and the highlight of this guideline is that it is provided outside the hospital, but by a trained medic or a paramedic, unlike the compression only life support, which was given by a layperson. So there are 4 essential co-links in BCLS, starting with early recognition and activation, then moving on to the delivering early high quality CPR, and then moving on to early defibrillation, and then transferring the patient to the nearest medical facility. So the basic algorithm remains the same, that is ensuring the safety of the place, then checking for the response, shouting or calling out for help. And here we check for the breathing while palpating for the carotid pulse, but one should make sure to spend not more than 10 seconds in doing so. So there can be 3 conditions arising from it, that the patient or the victim can be having a normal breathing with a definitive carotid pulse. If so, the patient is placed in a recovery position, reassessed every 2 minutes, and then shifted to the nearest medical facility. Or the second condition can be that the breathing is absent or abnormal, but there is a definitive carotid pulse that's felt. In such conditions, one can provide 1 breath every 5 seconds and reassess the patient every 2 minutes. And in the third scenario, where there is an abnormal or no breathing without a definitive carotid pulse, the cycles of CPR must be started, that is of 30 chest compressions and 2 rescue breaths. So getting ahead with the metrics of a high quality CPR, there are 4 components I'll be talking about. The first being the chest compression rate, which is from 100 to 120 per minute. The chest compression depth should be a minimum of 5 centimeters but not more than 6 centimeters. Any compression depth less than 3.8 centimeters will not give the optimum results of the CPR. The complete recoil of the chest should be allowed between the compressions, which will further improve the venous return and the cardiac output. For the ventilation, 2 rescue breaths are given after every 30 compressions, and it is assessed by a visible chest rise that's seen in the victim. So this is the pictorial representation of the CPR, where 30 compressions are given, and the approximated time to complete these 30 compressions is 15 seconds, followed by 2 breaths, where each breath will be given over 1 second, and 1 second would be allowed for the expiration. So for giving rescue breaths, airway opening is a mandatory criteria, which can be done by 2 maneuvers. The first being head tilt and chin lift. It relieves any upper airway obstruction, but in cases of any suspected underlying cervical spine fracture, to minimize the movements at the neck, jaw thrust is given. So continuing with the CPR, once we are done with the 5 cycles of CPR, that is each cycle comprising of 30 compressions in 2 breaths, and if at such a moment a defibrillator or AED is made available, then the pads or the paddle of the AED or the defibrillator must be attached to the patient, and it should be left to analyze the rhythm of the patient. So the condition that can arise from it is like the rhythm can be shockable or non-shockable. Shockable can be in cases of ventricular fibrillation or pulseless ventricular tachycardia, or it can be non-shockable like in asystole or pulseless electrical activity. If it's shockable, then 1 shock is delivered. Here we are talking about the monophasic defibrillators, which is charged up to 120 joules, and it can be escalated up to 200 joules for subsequent defibrillation. And if it's non-shockable, then CPR should be resumed. Once the defibrillator or AED is made available, one must not go for the palpatory method to check the carotid pulse. Instead, the rhythms should be analyzed using the defibrillator. So coming on to the placement of AED, the one of the paddle or the pad of the AED is placed to the right of the sternum, just below the clavicle, while the other is placed in the mid-axillary line, approximately over the position of V6 ECG electrode, and the pad should be clear of any breast tissue. While in children, mostly in less than 8 years, where the chest space is less, the pads can be placed in the front and back position. While delivering shock, make sure that no person is in contact with the victim, as by a quick visual survey and saying it loud, "I'm clear, everyone is clear." And then resume with the CPR. Moving on to the third guideline, that is comprehensive cardiopulmonary life support. It's a blue coded algorithm. And the key highlight of this is that it is performed or given inside the hospital by a trained medic or a paramedic. There are 5 essential core links in CCLS, being the first one being is the early recognition and management of the pre-arrest condition. The second being the early recognition and activation of code blue in the hospital. Then delivering high quality CPR, followed by early defibrillation, and then early comprehensive life support and post-resuscitation care of the patient. So the initial algorithm for CCLS and BCLS remains same up to the defibrillation, that is the use of AEDs or any manual defibrillators. The change what we see here is during the cycles of CPR, simultaneously, during the cycles of the CPR, a venous access is established. If there's a difficulty in establishing an intravenous access, intraosseous can be preferred as well in the femur or proximal tibia. And then consider securing a definite airway using an endotracheal tube. If it's not possible to place an ETT, one can also go for a supraglottic airway device. Then for drugs, administering 1 mg of adrenaline diluted in 10 ml of NSIV, and it can be repeated every 3 to 5 minutes. Then even antiarrhythmics can be considered for arrhythmia. For refractory VF or PVT, amiodarone 300 mg is given slow IV bolus, which is followed by a second dose of 150. Lidocaine is considered for refractory arrhythmia in the dosage of 1 to 1.5 mg per kg. And the most important thing is also to identify, investigate, and treat any reversible causes of cardiac arrest, if any. So this is the list of few of the reversible causes of the cardiac arrest. So getting ahead with the monitoring and the post-resuscitation care, during the cardiopulmonary resuscitation, monitoring the quality of rescuer's performance and the physiological parameters of the patient is quintessential. Monitoring end-tidal CO2, central venous pressure, and invasive BP are necessary to ascertain the quality of the CPR and its outcome. End-tidal CO2, if less than 10 mmHg, shows the failure of resuscitation, while more than 20 with sustained increase in other parameters as well shows return of spontaneous circulation. So to summarize, the CPR guidelines framed by the Resuscitation Council are limited to an amalgamation of the recommendations in the contemporary literature, suitably modified so as to be implementable in the available infrastructure. The algorithm has been made simpler, lesser voluminous, not requiring long periods of training or expensive periodic recertification. It also overcomes the language and educational barriers in a setup like India. Thank you.
Thank you, Dr. Shilpi, for a comprehensive overview of the ISH guidelines. I would like to invite, there are no questions in the chat box, so I would like to invite Dr. Mukul Kapoor, Dr. Moed, and Dr. Rakesh, and obviously Chakrao sir, to please enlighten and broaden on the subjects.
Dr. Joseph is not there. His presentation also was there.
Yes, sir.
Yes, I'm here.
So we should have his presentation before we sum it up.
Okay, sir. Okay, sir. We'll have the presentation.
Continue.
Yeah, it's my pleasure to introduce Dr. Joseph Abraham. Dr. Joseph Abraham is an alumni of Christian Medical College, Ludhiana, and he did his DNB from the Kerala Institute of Medical Sciences at Trivandrum. After that, because of his interest in pain and palliative care, he did his PDCC at AIIMS Raipur. Thereafter, another fellowship at the B. Brown Escalap Academy at Kolkata, and then did an MBA in healthcare services. He has worked in the Bundelkhand area during his senior residency, and is currently an assistant professor at the Manipal Tata Medical College, Jamshedpur. He has about 10 papers which are published and a chapter in a book titled Practical Bioethics. Of course, his primary interests are holistic pain medicine, medical education research, but today he's talking about a very interesting topic, and he's talking about assessment of pre-hospital resuscitation. The Indian Resuscitation Council Federation is very much interested in this field because we are the first people to introduce comprehensive the COLS, that is comprehensive
Compression only life support.
Compression only life support. So the word comprehensive was coming again and again. So it's compression only life support, which is the first thing which has made us popular. We have worked on it, and it is very nice to see that somebody is trying to evaluate the and see how people are doing the pre-hospital administration of cardiac resuscitation. Over to you, Dr. Joseph.
Okay, good evening to all esteemed seniors and colleagues. I'll just share my screen. Maybe I share my screen. Share screen. Okay.
In last week,
Yeah.
we will discuss IIF guidelines and what are the changes. Okay.
Yeah, so greetings from Tata Main Hospital and Manipal Tata Medical College, Jamshedpur. I am Dr. Joseph, Assistant Professor in Anesthesiology at Manipal Tata Medical College. I thank the organizers for this opportunity to speak on application of the Team Emergency Assessment Measure, that is TEAM, for pre-hospital CPR. My main references are Hans S. et al. And Cooper S. et al., who developed this assessment measure. So this is the take-home message. I'll come to the details eventually, but basically this is a tool. It is a questionnaire to assess team performance. So a cardiac arrest can happen in the hospital or out of the hospital. And this particular measure is to assess the out of hospital performance of the team. And why this came about is because they found that there is a low survival rate, about 17% in hospital and about 10% out of hospital if everything goes perfectly. As already Dr. Shilpi and Dr. Abhishek have discussed, this is the chain of survival, and there are multiple links in it, and it has to be performed in sequence so that there is good, better or best survival of the patient. I'll go straight away and speak a bit about high performance teams so that we can understand what is it that we are evaluating. So high performance teams, which I've abbreviated as HPTs, they are essential to the successful resuscitation attempt. So basically, when there is a resuscitation, either in the hospital, then it is a code blue, different people from different educational backgrounds. They could be nurses, they could be doctors, they could be senior doctors, junior doctors. So different people with different educational backgrounds. And if it is out of the hospital, then it may be lay people. They come together and they have to work together as a team to ensure that there is a good survival chance for the patient. So high performance teams are essential, and they carry out their roles in highly effective manners, resulting in superior performance. And what distinguishes them from just any other team is that they are committed to the resuscitation process, and they don't just simply follow orders. And at the end of everything, they evaluate, they measure their performance, they evaluate the data, and they look for ways to improve performance and implement a revised strategy. And how they do it is through this tool, that is the team emergency assessment measure. So for a high performance team to function effectively, they need to focus on four main things. That is timing, how to reduce the timing for the compressions, among other things, the quality, that is the quality of CPR, this has been already discussed, and coordination, this is very important. So the different team members should work together seamlessly towards a common goal, and they should be proficient in their roles. Another thing that is important is administration. There is leadership, there is continuous quality improvement, and there is a measurement of how the team performs. So if you see in the first part of this, you can see that there are three different parts to it. There is team leadership, there is team work, then there is the task management, and there is an overall assessment. I'll come to the details later. So high performance team, they are dependent on their roles and the dynamics, and they have to work together so that the tasks are divided, multiplying the chances of a successful outcome. Now, what are the elements of an effective team dynamics? There are certain roles, and there are some things to be communicated, what is to be communicated, and how it's to be communicated. Roles, the team members should know the clear roles and responsibilities. They should know their limitations, and they should be receptive to constructive interventions. What to communicate, that is knowledge sharing, and it should be summarized in the end and re-evaluated continuously. How to communicate is equally important. There should be closed loop communication. The message should be clear, and it should be always with mutual respect. Because in the team, everybody is equal. It does not matter if somebody is of a different educational background. So coming to the main topic, that is application of the team emergency assessment measure, which is short formed as TEAM, for pre-hospital cardiopulmonary resuscitation. The quality of CPR and medical emergency team performance has been questioned because of the low survival rate. And the determinants of effective team performance is mainly, there are two determinants, that is technical skills, that is how good we are in giving CPR, which has already been discussed, how to do it. But there are certain non-technical skills, such as leadership, teamwork, decision-making, and situational awareness, which also improves the survival rate. Just mere clinical experience is not a guarantee of competence, and teamwork needs to be learned, and it has to be practiced in safe simulated settings to enhance resuscitation performance. That is why we have all these courses, so that people can be trained and they can learn these things. It can be learned, and it can be learned with the use of patient simulators, such as mannequins or even standardized patients or computer simulations. And these can be even recorded and replayed and revised and improved upon. so that the outcome in real life setting is good. So it has been seen that many adverse medical events are attributed to non-technical skill failures. And it may be, like I said before, it may be exacerbated by the individual and the transient nature of the medical work. That is to say that suddenly event happened, the cardiac arrest happened, and different people, different individuals come and then they do the resuscitation. It is a very transient work, and they may not be regularly working with each other. So a variety of assessment tools and training schemes have been developed. Previously, they used to be self-reported, or your subordinates would report or rate the performance. But it has been seen that observational team performance rating, that means an external evaluator would observe how the team performs in a real or simulated setting and then give an feedback. So that is what this team emergency assessment measure is all about. It is evaluation by an external person on the performance of the team. So again, as I mentioned, communication and teamwork are important for patient safety. And this is a team evaluation tool for critical situations and emergency situations. The positive or advantage about this particular measure or assessment tool is that it has been actually verified in pre-hospital settings, and it measures leadership and teamwork in the resuscitation context. It is valid, reliable, and a feasible resuscitation teamwork assessment tool. It was developed by Cooper et al. In 2010 in English, but it has been subsequently validated even in French language. It is primarily an observational scale that measures team process and performance and the pre-hospital teamwork evaluation. So there are about 11 items in it, and it is rated on a 4-point Likert response scale. That is, 0 means never and 4 is always. And the score ranges from 0 to 44, covering about three dimensions. That is leadership, teamwork, and task management. And there is one more item, that is the overall team performance rating, and it gets a global scale, global score from 1 to 10. So this is the form. So you can see that if the Likert scale is mentioned over here, that is from 0, never or hardly ever, to seldom. That is 1, and 2 is about as often as not. 3 is often. 4 is always or nearly always. The team is identified with their data, and the 4 main aspects which are taken are the leadership. So leadership, it is assumed that either the leader is designated or somebody has volunteered, or it is a senior most person. And if that does not happen while this assessment is going on, it has to be rated 0. Team leader is an integral part of the high performance team, and every high performance team should designate a team leader. So the team leader will let the team know what is expected of them through direction and command. And the team leader should maintain a global perspective as compared to individual team members, where they will focus on their particular task. The second part of it is teamwork. So the rating should include the team as a whole, that is the team members and the team leader as a whole it will be. So in this, there are the team, whether they communicated effectively or not, whether they work together to complete the task in a timely manner, whether they were composed and in control of the situation, or were they emotional, or were they having a lot of conflicts, how the team morale was, because it is a difficult situation, cardiac arrest, and was the team morale positive or not, and how did they adapt to the changing situation. It is the clinical situation can change, the patient can improve, the patient can deteriorate, new data may be available, and how did they change or adapt to that position, to the change. And the team, how they monitor and reassess the situation, and there are potential actions. That is, are they prepared for the next step in the CPR? The third part of it is task management. Did the team prioritize their tasks? Did they follow approved standards and guidelines? And like I said, the fourth part is an overall or a global scale. It is a feeling of how good the team performed. Usually this team, it has to be, this form has to be filled out by a senior person who is familiar with the entire process and is not part of the team. So there are 9 elements, like I said: leadership, control, communication, cooperation, coordination, the team climate, their adaptability, situation awareness, prioritization, and the clinical standards. And the last one is the global rating. Now, the score is 0 to 44. It shouldn't be really summed up, but it can be summed up and the score can be taken, but actually individual scores should be evaluated as such. So a team leader, every team needs one, so they will model excellent behavior. So this is what we expect of a team leader. They should look at the global patient care. They should organize the group, monitor the performance, back up the team members. They should facilitate understanding, and if they are doing more advanced intervention, like maybe an airway placement, they should temporarily designate a team leader. And they should all, at the end of everything, analyze, critique, and practice for the next resuscitation. And another important thing is to train future team leaders. So the first part assesses the team leader and whether they have taken command and whether they are guiding their team members and whether they have a global perspective. The team leader and the team members should know their roles and responsibilities. Ideally, there should be 6 team members, but if there are more than 6 or less than 6, the team member should know how to delegate the task, and team leader should know how to delegate the task, and the team member should be able to communicate whether they can do it or not, and the team leader should encourage them to actively participate. So this is the resuscitation triangle. The main role is for the compressor, the person managing the airway, and the person with the defibrillator. And the additional roles are of the team leader and somebody who's managing the medications, the IV axis or the IO axis, and a person who records the time. Every team member should know the limitations, and the team leader should also know that their team member has a limitation. They should not burden the team member. So this is how the team works together. And each member should know that asking for help is not a sign of weakness or incompetence. It is better to ask for help because it will help the patient and it will help in the survival of the patient. So the teamwork is assessed in these parameters. So whether they communicated effectively, whether they worked together, were they composed and controlled, was the morale positive, did they adapt, did they monitor and reassess the situation, and were there any, were they prepared for the next step, and whether they manage the task properly, and are they competent and are they following the guidelines. So important, like I mentioned, is closed loop communication. Closed loop communication is when a message is given or assigned to a team member, there should be a clear reply from the team member that, and there should be eye contact. So, and they should confirm once the task is completed. So this is the loop is closed once they complete the task and they respond that yes, it is done, before being assigned another task. And if they cannot do it, they should say that they cannot do it. All the communication should be clear, it should be distinct, it should be calm and controlled. There should be no yelling or shouting, because that will be negatively scored on this assessment form. Whatever communication is there, it has to be with mutual respect. There should be no ego involved at all during the performance of the CPR, because that is against team dynamics. If at all somebody is not performing well, the team leader and the team members should tactfully intervene. There should be no confrontation during the CPR, and instead of that, there should be a debriefing afterwards. Right. So there should be a summarizing and reevaluation of what has happened throughout and also at the end of the CPR. So team members, they should be proficient in their skills. They should know what they should do. They should have good practice, that they should practice on simulations. They should be knowledgeable, and they should be committed to the success of the CPR. That is, the patient should survive. So why is it important? Because in 2015, the European Resuscitation Council, they emphasized on non-technical skills. And that is why a lot of studies and emphasis, but there was no way to measure it. That is why Cooper et al., they came up with this method. They came up with this measure on how to assess team performance. So what are non-technical skills? These are cognitive, social, and personal resource skills that complement technical skills and contribute to safe and efficient task performance. It includes situational awareness, decision-making, communication, teamwork, leadership, stress management, and coping with fatigue. Usually CPR is most frequently simulated medical situation and evaluated for these non-technical skills and team performance. The reason is that there are good guidelines on it. There are mannequins that can simulate cardiac arrest. There are standardized scenarios, and there is proven association between non-technical skills and team performance during resuscitation. So the standard measures of pre-hospital team performance are lacking, which makes it difficult to quantitatively assess the team performance of emergency medical services. This may be because in critical real-life situations, there are not enough resources to treat patients, hence there are no experts to participate in the objective evaluation. So as a result, most pre-hospital research is based on simulation training. That changed when this particular measure was introduced, when this tool was introduced, and actual real life CPR, pre-hospital CPRs were recorded and then later evaluated by experts. There are other tools also, like the Mayo High Performance Teamwork Scale. This is a 16-item scale, and it rates leadership, teamwork, communication, quality, and adaptability. And it focuses more on crisis resource management. And there is something called an emergency team dynamics. This also measures leadership and teamwork, but it lacks depth in the review of leadership and requires additional validity and reliability testing. So team emergency assessment measure is a tool to assess the performance of a team in a critical emergency situation like pre-hospital cardiopulmonary resuscitation, and it helps in objectively assessing how much the process can be improved so that finally patient survival is improved. And it is the only validated and reliable assessment tool of team performance. So there are some other scales also, like the clinical teamwork scale, the observational skill-based clinical assessment tool for resuscitation, and modified non-technical skills scale for trauma. But no teamwork evaluation team has been verified in actual pre-hospital clinical settings except this particular one, that is team. This is my bibliography, and thank you.
Thank you, Dr. Joseph. I think though you have covered it and you said that it has been validated, it is going to be very difficult to actually do it in a pre-hospital setup. You don't have teams of 6 people, and especially in a country like this, it's not possible to possibly do this kind of assessment. I would, since you've done a lot of study on the subject, I would recommend that you should work out your own scale, which is going to be more useful, which will be more practical, and which can be used by the Indian Resuscitation Council Federation. Since you worked on this in this field, it will be very good to have something from you, because the current ones which you have shown are more on IHCA based evaluation. It is almost a copy of the IHCA evaluation which somebody has tried to incorporate into pre-hospital, which is not possibly easily unless you have such big teams of 6 people who are going out and doing the OHCA. It's not possible. I would like to hear comments about it. Thank you very much, Joseph. Anyway, it was a very good presentation. I'm sorry I've pointed this out, but it's not your fault. It is the fault of the person who designed it, not your fault. And thank you very much. It was a very good presentation. And now I'd hand over to the organizers to take it further in whichever way they want to. Thank you.
Sir, I would like to say a few words about that, because that Indian Resuscitation Federation Council, and they published their guideline on the cardiopulmonary resuscitation. So we have 4 people here who are having role in accumulating all those things. You, sir, Mukul Kupar, sir, Chakra Rao, sir, Mohit, sir, and Rakesh Garg, boss is there. So I feel that can you elaborate all those things, because most of the here juniors were asked questions regarding what is the difference between that. And one more thing, that something major done about the naloxone. So can you clarify this one, sir?
Should I take?
Yes.
See, we have a for this, and it is the format of the training of the trainers in IRCF training system. We have a separate session, means frequently asked questions, which has been taken by me most of the time, and I can tell you certain aspects of them, which is again, as you said, that how do you go ahead with it? How did you frame it? Primarily, your question is, how do we frame this guideline? You need to say
Yes.
that, isn't it?
Yes.
So naturally, if you see, we collected all those questions because before COVID-19, we had this guideline in 2017, where after launching this guideline, we went to all corners of India, and we tried to collect all those questions, which was put forward to us and asked us in the platform. And it was an open discussion. So wherever we went, we tried to, when we launched our guideline, we projected amongst the audience, and everyone asked us questions. And from the very beginning, we started, collecting those data, those questions, in fact, and we tried to answer those questions, whatever was given to us. So I just can tell you certain questions which was given to us, which obviously will tell you, which will always, I think it will clear your, objectives, what you want to actually know about it. So to just highlight certain aspect of it. So first is, if you see, you just see the difference between our guideline and the international guidelines. So if you say that, you see one of the most important aspect of our guideline is a color coding system. We have a color coded guideline, which is primarily being projected for different class of people and different areas of resuscitation. If you see, you have as the lady, the junior doctor resident said, that is the yellow color was primarily based for compression only life support, which was primarily for lay people. And then we have green, which is outside the hospital. And then we have blue, which is again inside the hospital, which was comprehensive cardiopulmonary resuscitation, like cardiopulmonary life support. So they were all color-coded, one. Secondly, if you see, it is a standalone guideline, which can be incorporated in the subsequent guideline. Means one can take it over in the subsequent guideline. And third is, it was primarily targeted to people where we know that we will not be able to take those guidelines, which are other international guidelines, which will not be able to make them learn those practices. So we all, based on certain skills, we were easily accessible, easily learned. And so we highlighted those skills for particular section of people. So for instance, cardiopulmonary compression only life support is primarily based targeting the lay people, where we know that if you see the researchers, most of these studies, they said that even with just compression, you can make a person survive for a period of 10 to 15 minutes, provided it's an acute cardiac, me to say, patient is not chronically ill health. So there, obviously, you can make this patient sustain. So meanwhile, if you can go ahead with it with only compression, you are avoiding the other component of the standard compression, standard cardiopulmonary resuscitation, which is also having, in addition to that, we have the mouth-to-mouth breathing, or you can say the airway breathing component as well. So that has been kept as, away from the compression only life support, keeping in mind that it is very difficult for a person the mouth-to-mouth or a bag mask ventilation or a pocket mask ventilation, so which is not easily available, firstly, and then even if it is available, it is not very easy to learn it and then achieve that target which you want. In fact, if you see the researches, it causes more harm. This patient aspirates, because if you're trying to ventilate this patient and inflate the stomach instead of the lungs, then obviously it is much more detrimental to these patients. So we stuck to a component which is very easy to done, safe, and it can be achievable. So that was one important aspect. So this is one very different from where we launched it and world accepted it, and most of the countries are now accepting this. Secondly, the concept was, if you see, the other component is, as I said, it is target oriented. It is also our limitations in different, so because we know that 70% of our population is in the rural health, where probably will not have those equipments with us, will not be able to reach the area within a very short period of time. The facilities available, the requirements which is needed is not there conducive for a particular section of people. So naturally, we try to cut short those techniques which is needed. So this was one different. And then, as I said, color coding was different. And as I said, again, integrated and standalone system. And third is that if you see the studies, the DART study, if you see the DART study, which is dispatcher assisted resuscitation trial, there if you see, they had a hypothesis that CPR with a compression, chest compression alone, or with CPR, which is a standard CPR where you have a chest compression with a resuscitation component, I mean the breathing component, or with only a CPR, only one chest compression component. And what they have seen is that when they did with chest compression and breathing component, the resuscitation survival to discharge hospital, surviving to hospital discharge was 12.5% in compression only, in which was in comparison, we have 11% in compression along with rescue breathing. So you can see there's a difference. That means only compression can make a better outcome instead of going for a compression along with rescue breathing. So this is one DART study which we have, and it's very important to, if you go ahead and go through this study. And if you see, the hospital discharge is also better. It's 14% in comparison to 11% with the rescue breathing. So this is one very eye-opening study for us. Then you have the SHARE study. If you see the SHARE study where the Save Hearts in Arizona Registry Education Trial, if you see, they had evaluated 2,000 plus and 2,300 plus patients, and they divided into three. So So they divided into three components. One was the patient who did not receive CPR, patients who had received CPR by bystanders, and patients who had received chest compression by only telephonic resuscitation. And what they have seen is that when the patients who were waiting for the CPR to be conducted till the EMS team came, it was 32% of these people with no CPR before the EMS arrived. You can just imagine. 23% people, they received bystander CPR. So if you know the CPR, even then only 23% is. But over a telephonic CPR, they have 43% of the people they receive CPR. So what I mean to say here is that by just telephonic CPR, where you just tell the patient that the person that you go with the cardiac compression, that is much more better, because we know that there are two concepts. One is no flow and low flow. Low flow is better than no flow, means even whatever resuscitation process, whatever compression you do, if that compression you will be able to at least achieve some amount of flow to the brain than to have no flow for a period of time. So what I mean to say is that even if you just go on giving a message through a phone, probably you'll be able to achieve a target which is better than the EMS arrives, or better than a bystander arrives, or better than no flow at all. So this was, and if you see that study, the SHARE study, they have shown that the rate of survival was triple than patients who were not receiving any CPR. So just telephonically, if you just tell them you go with the compression, that is going to give a better outcome, triple that outcome which a bystander or an EMS team comes and goes for a CPR. So this is a very important study. So that also tells us, that also motivated us that obviously we can just stick to cardiac compression, just cycle it till the other people, the advanced people comes in, or the BCLS people comes in, and then we can go ahead with this trial. Now let me give just one simple example. For instance, all the people who are sitting in front of us, they are all experienced doctors. Now let me give you an experience, what I have felt myself. I've done a study on this. Now in an hospital, when a patient survives in the ward, let me tell you, not in the operation theater or an intensive care unit, in a ward, when the patient sustains cardiac arrest, what is the first response? You start doing just chest compression, nothing else. Before the code blue is being given, or before you have an advanced system team comes in, or before you put and back mask ventilation, the first response goes a chest compression. So what I mean to tell you is, even in the hospital, the first response is COLS. So my thing is, so that is one of the most important thing which IRC have come across with, and it has projected, and it has been worldwide accepted. The second thing is, we have not highlighted any time. Our system does not have any time system. It's not that international guideline go for 2 minutes and then you go for this, nothing like that. We highlighted on cycles. 5 cycles, repeat it again. 5 cycles means 150 compressions, go ahead with it. This is for COLS I'm talking about, not for the other BCLS and so on and so forth. So this is something, and as I said, breathing, if you go on with the studies, whatever international studies you have, breathing component is much more difficult to learn and much more difficult to implement. Say, for instance, in an open circulation, if an open system, in an Indian scenario for that matter, if you see a CPR being done by a person, would you like to go for a mouth-to-mouth breathing, or would you like to go for rescue breathing? No, because you are hesitant, or you don't know exactly who the patient is. But of course, you can go ahead with your patient who's inside, who's your relative. So naturally, that component we have tried to avoid in an COLS component. Now, let's tell you one thing, one very important eye-opening to all of you, that if even the ERC, if you see the ERC, what the European Resuscitation Council said, that those lay rescuers who are unwilling to or unable to go for give mouth-to-mouth breathing, let them not go for mouth-to-mouth. Even the compression hands-on CPR is good enough for making the patient survive. Even AHA, after our implementation, they have also, yes, only by the hand-on CPR is much better than going for the rescue breathing as well. So these are certain things which obviously we went on, and if you see now, let me tell you about the bit component, which has a lot of people have asked about our method of giving the defibrillation in a BCLS group. So if you see the BCLS, we have given the defibrillation, and people have inquired, people have raised questions on that why did you start with one? And the other question which I asked was, as Dr. Mukul Kapoor has very rightly said, that we have specified ourselves to 120 compressions per minute. And this is where we want to be very specific, because whatever you're doing, you have to achieve a precision. One thing, don't make the patient confused by telling that giving a range, because range means you can do it with 100, you will do it 120. So when you give a range, you'll be confused. Why not 100? Why not 120? Why should I take a range? Why not? Because when on one side you are saying specifically it should be not less than 5 centimeters. On the other side, you are saying that it should be 100 to 120. So that is something which we are really made fixed, and 120 is something which, because the studies have said 120. The second thing is, if you see the position of our guideline, the position of our guideline is very specific. If you see the studies, especially the Asian studies, if you see this Asian studies where they have done and CT scan, the CT scan have very rightly proved that when you go with a midline compression, that means the line which is touching the two nipple, you're primarily giving a compression at the root of aorta. So when you give at the root of aorta, means you're causing not at the level of ventricle, but at the root of aorta, means where you're causing more obstruction to the flow of the cardiac output, flow of the left ventricle, instead of letting the ventricle to empty the blood. So naturally, this is something which CT scan has proved. Even the TE of another study, they have also shown that when you do a cardiac compression at the level of your nipple, probably you're causing more obstruction to the outflow of the cardiac output. So this is the study. So we stuck to our system, and now they have, in the recent guidelines, they have said, yes, it is the lower sternum, mid sternum, but lower part of the sternum would be a better choice instead of middle of the unimaginary line and touching the two nipple.
One thing I would like to ask from Rakesh Gargos, he is there. So because team approach is necessary, and most of the time we are nowadays every society is taking the BLS and ACLS guidelines. So team approach regarding suppose that in pre-hospital area, can you elaborate, sir?
Right. So I will put and elaborate on what Dr. Mohit has said, that this question is quite common, that why should we compare guidelines? What's difference between the guidelines between others? So I'll put it simple way, right? If JP calls me, Dr. Jayaprakash calls me to his state, I will obviously enjoy litti chokha of your state, right?
Yeah.
We try to make it in Delhi, I will never have such a flavor and never will have such a company. But if you come in Delhi, I can have the continental food for you. If you go to Punjab, you can aloo prathas. When we
Yeah.
don't compare the speciality of a place, because that's a speciality, that's the need, that's what is grown there, and they know it well. Same would be applicable for guidelines. So I have a humble request that we need to stop at some stage comparing the guidelines.
Yeah.
All guidelines are good. They have been developed for their reason, for their place. And that's the reason ILCOR takes all the resuscitation councils under one umbrella. If they're all councils, we should not be comparing it. Now, I'm sure Dr. Jayaprakash is one of the international researcher and he's part of various teams. He can elaborate on that aspect also. When we talk of evidence-based medicine, it has 3 pillars, or now say 4 pillars also. It is just not the research publications. Evidence-based medicine works on the expertise, the requirement,
Yes.
patient values, and the contextual need. So this is what the evidence-based medicine is. And same is applicable when any council, including the Indian Resuscitation Council Foundation, has made the guideline. It was, evidence is across the world same. The research is being published on international forum. But that science, resuscitation science, has to be interpreted and make it applicability on the requirement of our own country. And that is what we have done. And that is, we have been recognized by ILCOR to be part of this team. So I would request, there have been certain things where there have been pro and cons, there have been comparison, there have been comparative chart. And even I have been asked multiple times, why don't you publish an article in which all the guidelines are compared? I said, there is no use of it. All guidelines are good, but in India, we need our own guidelines, which Dr.
Yes,
Mohit
yes.
has, why we have done it. Second question coming directly to you, talk about team approach in the pre-hospital.
Pre-hospital. Yes.
Right. So when we say a team approach, team is basically a group of people who are doing the work. So I'll put it in another analogy. All of you must have seen the dancing sequences or choreography. Now, each member of a choreography knows that what other members are doing it, and they make a choreographed steps for everything, isn't it? Same is applicable for medical science. Same is applicable for resuscitation science. So when we say teamwork, there will be multiple of works which needs to be done timely, because time is essence in CPR, in resuscitation. And now, who will be the team members? So we know the steps, right? We know that somebody has to take a scene safety, somebody has to call for help, somebody has to do cardiac compression, somebody has to gather the information from the family members about the patient pre-existing comorbidities. So this team can easily be made. It's not a rocket science. Only thing is, we need to identify a person and we need to delegate the person specifically. So I will say, Dr. Mohit, can you just go around and check for the scene safety? I will say, Dr. Mukul, can you ask the patient family members to know about the history? I will say, Dr. Chakra Rao, can you just look for and call for the emergency help so that the ambulance reach here? So this means we are dividing the delegating work. And if you want to create a scene safety, who should be the team member? Everybody can be the team member.
Yes.
Even an illiterate person, if you say, just cordon me around so that I am safe and my patient is safe, you can even ask an illiterate person, he can do it. You can ask a 14-year-old child, he can do it. So I think creation of a team is again contextual. The only thing is, we need to create an awareness.
Yes. That is most important thing. And
Yes.
this is the first thing. What I want to listen from your side, that awareness is most important thing, because we are most populated country in the world.
Yes. So I think such type of programs, like even this type of conferences, webinars, and creating public awareness, I think we need to do in a more broader level. We should be all inclusive. All specialties should come up. We are getting good support from other agencies like government agencies, CBSC, Even the Mantralaya is supporting us for bringing out these activities. Even politicians are coming to us. Even actors are coming to us. So I think we need all inclusive of all those things so that we create awareness. When we create awareness, public demands for it. When public demands for it, we release them. So I think team is nothing, but it is a group of people with their similar intention, with good intention, and we can create it. I think work like you, like Bihar Jharkhand ISA group, I'm sure you people are doing great work, and this will create more awareness among the lay public.
In fact, if you see, Dr. Prakash, that is what I said, we said opening session, that it has become a buzzword, CPR, and that is why we are trying to make it much more easily accessible and aware to most of the people. And this awareness has come once there was a launch of the guidelines, Indian guidelines in the Indian context. So this awareness has been really much more improved nowadays. And one of the most important thing is this awareness and accessibility becomes much easy when you make things very simple to them. If you make any work which is very simple and easily accessible and understandable, then they try to accept it. And that is what when they accept it, they try to propagate it and promote it as well. So this was the primary reason why nowadays, if you see, CPR has been really accepted by even the school children. And we know school children is a brand ambassador, because we know they are, if you can make a school children learn CPR, they're going to tell their parents. And in every house, we have an elderly people where this school children can at least go in the COLS and perform any sort of MI, any sort of cardiac events which is taking place in their house, and they can make the patient survive. So this is what is most important. We make the things very simple. It becomes much more easier to accept it, and that is how we make people aware of it. So this is one of the most important things.
You concluded all the things, sir.
One word for me.
Sorry, sir. Yes, sir.
I tell something.
Yes, sir.
Yeah, you conclude that session, sir.
Yes. I think Dr. Mohit has clarified the differences and the need for the Indian Resuscitation guidelines. Actually, these Indian Resuscitation guidelines, when there was a survey in 2016 by Labret, actually it is shown that only 2% of the Indians know CPR. So by this, many of the sudden cardiac arrests that are occurring outside the hospital, actually about 80 to 90% of the cardiac arrests occur only outside the hospital. They are 100% or 90% are going succumb to death. So in these circumstances, and when ISA thought of that we should have our own guidelines, we brought this, and it is nothing but the bystander CPR. We wanted to make it more popular because we do not have a very good emergency medical system. Our ambulances have no etiquette. Nobody will give a green channel passage for them, and they are almost always locked up in the traffic. And we do not have very good ambulances. Even 108 is there. There are certain issues, and we do not have reachable roads and the language differences, customs, and all those things. So first of all, we wanted to introduce the compression only life support till the help comes. So rest of the things are almost the same, except what you have told that we have clearly specified that 120 compressions per minute. And another thing is the number of joules of shock that is giving and given suggested by us. All those things were clarified by Syed Mohit. The another important thing is many people are trying to do, and it is only limited to the CPR teaching is limited to the corporate hospitals and very high sounding areas. It is not learned by the people in small towns, and it is very expensive in those days. And now the Indian Resuscitation Council Federation has come, and we made it a very affordable way. And we wanted to establish a CRTC, we call it a CRTC, Comprehensive Resuscitation Training Center in every district, so that people can go and learn there with a nominal price. Even the nurses on whom we are very much dependent, or the paramedics or the technicians whom we are very much dependent, it is very difficult for them to go for a training because of the cost. So now we have decreased the cost by Indian Resuscitation Council Federation, and nothing we need not share anybody, and so we made it just for a certificate and the manual. We charge only 550 rupees, including the GST and the courier charges, and it is up to you to train them. The training, there are little differences. What we wanted to tell, we can tell you and make you our Indian Resuscitation Guidelines instructor, and it is up to you. We do not want you to charge too much for the paramedics. Of course, doctors think that they know everything, but it is very difficult for us, what we have observed, that to change their mindset is little difficult, because even many people, they talk about the 2010 AHA guidelines and try to incorporate into the present situations. So it is difficult, but whatever it is. So what we want is every citizen a lifesaver, and it should be spread throughout India to every corner. And I think last year we had a similar meeting in Bihar. And again, if you want our team, we can send our team, Rashid Devar and Saeed Moeed, they will just make you to, practically there is not much of a difference. Whatever you are telling, all the speakers are good. And of course, Shilpa is, again, even in the Indian guidelines, she has repeatedly told that 100 to 120 compressions, but it is not 100 to 120, it is only 120 compressions, because we don't want less number of compressions if you keep it a margin of 100. So that is all proved beyond doubt. So whatever this is a very, very less expensive, not less expensive. It is all what we do not want to build up mansions with this. What we want is to spread the message, spread CPR, and save lives. And we do, and even our instructors, of course, all of us, we are just working for our pleasure and everything. And whatever in Andhra Pradesh, we have established about 40 training centers already in every medical college, in every district. And not only that, last 3 months we have trained 10,000 nurses, even in the district and the taluk hospitals. And now we have made it a rule. I could influence them and made it a rule to train all the nursing students in the student level itself, so that they will be knowing, and it is also we made it mandatory to teach CPR. Of course, NMC is also telling CPR at the student level. And when they come to the clinical level, or when they come to as a nurse surgeon, it will be very useful for them. And we wanted to spread this message. And we don't, if this is made in India, we don't lose any Atmanirbhar Bharat. We don't want lose any foreign exchange out of this. And let us work together, and please own this guidelines as everybody's. Thank you very much.
So before last but not the least, before closing this session, as per our protocol from the Bihar Jharkhand Society of Anesthesiologists, we are always handing over the certificates to our moderators and speakers. So first, I would like to request to Chakra Rao sir to please hand over the certificate to our moderator, Dr. Mukul Kapoor sir.
Okay, thanks for giving me the opportunity. Dr. Mukul Kapoor, I think you can download this certificate, and I'm very happy that any credit hours for this. I think you have not applied for that. Okay.
Yeah.
Thank you.
Now I would like to request to Mohit sir to please hand over certificate to deliver the certificate to Dr. Nishant Kumar sir.
Congratulations, Dr. Nishant. It was really pleasure and honor to be there with you and experiencing your knowledge as well. Over to you. And this is an excellent certificate being given by BJSA. I hope you'll be honored by receiving this.
Thank you, Dr. Moeed and BJSA. So I'm really honored to be a part of this meeting, and I do hope to be a part of future meetings. And this has been a wonderful session. And especially, I would like to congratulate Dr. Joseph for his presentation on the team approach. Other speakers also, but since I am involved with the training of pre-hospital trauma technicians, so that was a bit close to my heart. Thank you so much.
Thank you, sir.
Now I would like to request to Dr. Rakesh Garg to please deliver certificate to our first speaker, Dr. Abhishek Chatterjee.
Thank you, Dr. Jayaprakash, and very congratulations to Dr. Abhishek Chatterjee. It was a wonderful session, and I'm sure this will create more awareness and more research will be coming to us after these type of sessions. So thank you, Dr. Abhishek, and congratulations also for a wonderful session.
Now,
Thank you, sir.
Now I would like to request to Dr. Mukul sir to please hand over certificate to our second speaker, Dr. Joseph.
Dr. Joseph, you spoke very well. Thank you very
Thank you,
much
sir.
for the presentation, and all the best to you in your life. Thank you.
Thank you, sir.
Now I would like to request to Dr. Nishant Kumar sir to please hand over certificate to our third speaker. Although she is first year resident, but she spoke very nicely, Dr. Silpi.
Congratulations, Dr. Shilpi. It is brevity is an art, and you could summarize and explicitly tell all the three guidelines in a short period of time and clearly explaining the salient features. Congratulations again, once again, Dr. Shilpi.
Thank you so much. Means a lot.
Now I would like to request to Neelam ma'am to please deliver vote of thanks to our participants and moderators, chief guest, guest of honor, and all the audience, please.
One more thing, actually, we have started one journal of resuscitation recently, where Dr. Moeed is the editor-in-chief. So we request some publications or articles on this. And not only that, and we are now updating the our working manuals and the guidelines. And also we are forming one a committee of research on this. We wanted to spend some money on this, and we wanted to establish a committee. And another thing is the registry of cardiac arrest also we wanted to, with your help, with big hospitals like Tata Main Hospital or Tata and other hospitals. Definitely we can note down the cardiac arrest, incidence of cardiac arrest and the causes. So definitely we can make a very good registry. With that, we can arrive at some conclusions and research. So that I wanted to inform you. Definitely we will be informing you and making a part of us and be successful. Thank you.
Yes, thank you, sir.
Neelam ma'am.
Neelam ma'am,
Yeah.
please.
So I'll start with a क्या कहते हैं कविता आज मैं ऊपर और आसमां नीचे. So congratulations to everyone for this special day. Honorable dignitaries, distinguished guests, and dear participants, on behalf of the Bihar Jharkhand Society of Anesthesiology, it's an honor to have the opportunity to express my deep sense of appreciation for being present here. I'm extremely grateful to our chief guest, Dr. S.S. Chakra Rao sir, for his gracious presence despite his busy schedule. Without his presence, webinar on CPR would not have been so interactive and successful. Thank you, sir. Thank you for your presence. I would extend my hearty thanks to our guest of honor, Dr. Syed Moeed Ahmed sir, who has special interest in airway management, CPR and critical care. And I remember when I was student, I attended few of his classes on airway management. Thank you, Dr. Moeed sir, for being present. Our special gratitude to our moderators and Dr. Professor Mukul Chandra Kapoor sir and Dr. Nishant for conducting the entire session so smoothly, making it so interactive, and everyone participated so nicely. Our special gratitude to Dr. Rakesh Garg sir, Editor-in-Chief of Indian Journal of Anesthesiology, for his expert opinion and gracious presence. Thank you all the dignitaries for your thought-provoking insight on this is very important life-saving topic, that is CPR. I extend my sincere thanks to our esteemed speakers. Rather, I will call them the stars of the evening. Dr. Abhishek Chatterjee, Dr. Joseph Abraham. The last word I will not pronunciate because it's very difficult for me to pronunciate the title. And Dr. Shilpi for their wonderful, crisp presentation well in time and their sincere efforts in making their topic so lively and so fruitful. My sincere thanks to our IT partner, Mr. Anand, without whom these webinars which we are running successfully since last 2-3 years would not have been possible. And even in COVID times, we continued our all webinars with his help. Last but not the least, my deep sense of gratitude to all the office bearers and members of BJSA for organizing this webinar and making and rather taking all the efforts to make it better in every meeting, guiding and helping their speakers for making their presentation, talks, providing the material. So like we make a group for the entire month and we keep on asking, do you need any support? Do you need any help? So that they can come out with their better presentation. Thank you everyone once again for your valuable time. And see you all again next month. Till then, good night and enjoy looking at moon. Thank you.
Thank you, ma'am.
Thank you.
Thank you.
Thank you. Good night.
Thank you, Dr. Neelam.
Thank you, Jay Prakash.
Good night, sir. Good night, everyone.
Thank you,
Good
sir.
night.
Good night.
Good night, everyone.
Good night.
बढ़िया सेशन था.
काफी इंफॉर्मेटिव और प्रेजेंस भी अच्छा था. प्रेजेंस तो इतना अच्छा था, मतलब स्टार्टिंग में तो 78